Good afternoon, and thank you for joining us for the town hall, the COVID-19, the African American community, Equitable Vaccine Distribution Part 2. My name is Trudy Hall, and I am with the Program for Multicultural Health at Michigan Medicine. Next slide. Again, I want to thank you for joining us, and we will be taking questions. Panelists will be taking questions. If you have any questions, please submit them in the Q&A tab on Zoom, or if you are joining us live on Facebook, in the comment section. One of our local panelists, our local pastor, Pastor Mashad Evans, will have to leave early. So if you could please submit your questions to him as soon as possible. That way he can answer those when his presentation is done. All other questions, if you could submit by 1:20 or 1:25, would be greatly appreciated. Next slide. Again, our town hall today the purpose is to educate and inform you. And if you have any specific medical questions, we urge you to talk to your own local healthcare provider or contact your local health department. Next slide. We want to thank all of our different partners for supporting our event today. We have a very large work group of health partners and community partners and our faith-based partners who've been supporting us. And the slide in front of you identifies some of the partners, and I'll just highlight a few. Of our partners are New Hope Baptist Church and Bethel AME and St. Paul Missionary Baptist Church in Ann Arbor. We are also been working with Community Family Life Center and the Turner African American Services Council. Slide. I want to introduce our moderator for today. Our moderator for today is Keela Samuels. She is a clinical pharmacist and researcher in the Division of Allergy and Clinical Immunology at the University of Michigan Health System. She is a faculty and a department chair at Washtenaw Community College. She is an active student educator, being recognized with both the Preceptor of the Year Award and Preceptor Recognition Award from the Association of Allergy Participants. Dr. Samuels attained her Doctor of Pharmacy degree from the University of Michigan College of Pharmacy. And next slide, we'll go on to Dr. Samuels, who will introduce our panel.
Well, thank you so much, Trudy, for that very, very nice, warm welcome. I am excited to be here this afternoon so we can continue the discussion on the Equitable Vaccine Distribution Part 2. So we have some wonderful panelists who have joined us this afternoon, and I would like to introduce you to them right now. The first is Reverend Mashad A. Evans, Sr. He is the senior pastor at Bethel AME Church in Ann Arbor. A New Jersey native, Pastor Evans is an ordained itinerant elder in the African Methodist Episcopal Church. Pastor Evans has served in congregations in Boston, New Jersey, Alabama, and Michigan. With a passion for history and social justice, Reverend Evans is committed to holistic community-based ministry. Pastor Mashad holds a Bachelor's of Arts degree from Rutgers University and a Master of Divinity from Turner Theological Seminary. Welcome, Reverend Evans. Next, our panelist is Elfrida Rooks. She's the Director of Community Health Services for Michigan Medicine at the University of Michigan. She works to advance important mission to identify creative solutions to address health and social needs for communities where Michigan medicine resides. Ms. Rooks' experience includes extensive background in training and guiding and mentoring teams and building collaboration at all levels. She holds a master's degree in public health administration. Elizabeth Vanderpool, she's a regional director of community health and well-being for Southeast Michigan. She works with Trinity Health in Michigan and is the local director of community health for St. Joseph Mercy in Ann Arbor. She's a public health professional with 12 years of experience in public health and in the healthcare field. Beginning her career in behavioral health, she recognized the barriers that many patients face in accessing care and how that prioritized whole body wellness. She also holds a master's degree in public health. Our last panelist is Cindra James. Cindra is an emergency preparedness administrator with Washtenaw County Health Department. She is an experienced administrator who has demonstrated her history in working in government administration industry. Cindra attained her master's of public administration from Central Michigan University. Let's welcome our panelists for today. And first up will be Reverend Evans.
Good afternoon, everyone. My name is Mashad Evans, and I serve as the senior pastor of Bethel AME Church here in Ann Arbor, Michigan. I'm pleased to be with you this afternoon and want to thank those who have worked together to bring together this virtual town hall when it comes to equitable vaccine distribution. I'd also like to share a disclaimer that the opinions that I share in this presentation, short presentation, is not reflective in any way of Bethel AME Church or the African Methodist Episcopal Church, but rather my own views and opinions and experience. Bethel is a congregation which since 1855 has served its parishioners as well as the larger community. And it is one of the older African-American congregations in Washtenaw County. We're part of a larger denomination known as the AME Church, which was founded by a man by the name of Richard Allen in 1787. And in 1793, Richard Allen was an individual who helped to work with other African-American parishioners in fighting the yellow fever pandemic that struck Philadelphia that year. He was invited to serve by a man named Dr. Benjamin Rush, who thought that African Americans were less susceptible to the yellow fever pandemic. And he encouraged them to help other individuals living in Philadelphia to serve as nurses and aides for those individuals who were suffering. It turns out that African Americans were no less susceptible, and many of those volunteers actually contracted the virus and died themselves. As part of that experience, there had been some very negative press giving the African Americans, about the African Americans who served in Philadelphia during that time. And so Richard Allen wrote a pamphlet suggesting that, people who served in the capacity, those frontline and essential workers, were very much a part of the larger American community, a larger Philadelphia community, and needed to be viewed as such. And I just give that as a historical background that for over 200 years now, African-American congregations and pastors and parishioners have dealt with some of the inequities when it comes to the public health system. Over these last several months, when it comes to the COVID-19 pandemic and what we have seen throughout the world, the nation, and even here in Washtenaw County, the experience of many of my parishioners has been one of a lack of access. And that has been remedied in many ways through what we've seen over the last few weeks. And just want to take this time to also shout out Michigan Medicine and the Washtenaw County Health Department in doing what I believe was the right thing to help address some of these inequities and lack of access. The congregation I serve, we are predominantly older, that the average age of our congregation is 55, that most of our volunteers and those who support the work that goes on here at Bethel AME Church are individuals who are in their 50s and 60s, many of whom is 55, that most of our volunteers. I'm sorry, I was just getting a little bit of feedback. That's why I paused. And there are individuals who are elders, those who are also part of our congregation, many of whom have pre-existing conditions, comorbidities that make contracting the virus all the more lethal. In fact, there are 4 members who have passed away since March of 2020 due to the COVID-19 virus. And so this has impacted our congregation, not only our members, but we have members who have immediate family members, mothers, fathers, brothers, sisters, sons, daughters, husbands, wives who have contracted the virus, some of whom have passed away, but we're grateful that most of them have survived. And when it came to the distribution of the vaccine earlier this year, it was challenging for many of our congregants, especially those who were not as technologically savvy or technologically fluent, accessing the information. For case in point, many health systems had designated either websites, links, portals, telephone numbers to access information regarding the vaccine. And so if you were to call one of the health systems, one of the first messages you would hear would be, your primary care physician has no information regarding the COVID-19 vaccine. You need to call another number or go online. And for individuals who don't have that capability, whether they don't have access to the internet or they don't have a primary care physician, that proved to be a roadblock. That in and of itself created even for lack of a better term, a sour taste in the mouths of many of the parishioners, and not simply of Bethel, but of many people of color throughout Washtenaw County. And to know that African Americans were disproportionately impacted by this virus, but yet and still access to the vaccine, there was many stumbling blocks and hurdles. And in an age of social media, where there are many people who put information on social media to see other individuals who are receiving the vaccine who may not fall in what we would consider a vulnerable category, it just added greater stigma to the fact that, I'm not saying that that was the reality, but the perception was that the health systems were taking care of themselves and individuals who worked within the health systems. And so over the last several months, I've been part of several conversations with the Ministerial Alliance, as well as the public health systems, and to see the way in which the systems have really kind of risen to the occasion to address what was perceived as the inequities, and not just the perception, but the real challenges with access. I think that the county health department has done a tremendous job, as well as the health systems as well. On March the 22nd, Bethel was able to host a COVID-19 pop-up clinic to help to meet the needs of providing vaccines for individuals in certain, not income brackets, but zip codes, those who might have fallen into a social vulnerability index. And within 3 hours, we were able to provide vaccines for 176 individuals. It was very well organized, it moved very smoothly. And to hear that those numbers have only grown in the terms of those who were able to be vaccinated. So after Bethel AME Church, there was Second Baptist Church in Ypsilanti. I believe they were able to vaccinate over 200 people. And just the information, the way in which it was shared, the way in which it was distributed, the registration process, everything moved very smoothly. There were some hiccups, but of course, in any sort of campaign or any sort of project of this magnitude and doing this for the first time, there would be. But all in all, my experience, and I know it might seem anecdotal, has been one that has really kind of reaffirmed a sense of equity within our healthcare system. That, of course, there are a number of challenges and there are biases with which we are still working. So I'm not saying that everything is perfect, but in the context of what we have seen over the last few weeks, in regards to that which we saw for the first several weeks of the vaccine distribution, it really has been eye-opening, and it's given me a sense of courage and confidence as we move forward in this fight. Um, I am excited about how these pop-up clinics have gone. There are still, of course, many, many more people who need to be vaccinated. And I think just to see how the churches and church leaders and congregants have been a part of this experience has helped to abate some of the stigma that individuals may have in regards to receiving the vaccine. So I'm encouraged, and I am proud of what the health department has done, and proud of the partnership that they have established, not only with Bethel, but other congregations across this county. And I'm looking forward to where we go from there, or from here.
Wow, thank you, Reverend Evans. That's amazing, and thank you so much for giving us that history. And sometimes we are like right in the middle of this pandemic, and we know that there has been other pandemics before us. Every 100 years it seems to cycle.
Mhm.
It is knowing that the church was way back then. What you said, a history of 200 years ago, being involved, because we all have to collaborate. I love that word, collaboration.
Yeah.
Making it all work together as a team, because it really is a team effort. So thank you for giving us that history. And I am so glad that we were able to address some of those stumbling blocks that we had early on. I remember having many, many meetings about some of the barriers that we had. And so the pop-up clinics definitely was something that has taken a lot of people have interest in, and we have done a lot of good work that way. So I do have one question. I know we're moving in the right direction, but can you think of anything that, there's more stumbling blocks, right? So what would you think in your mind is the number one, or our next step for your congregation, for people that you are around, that we should do as healthcare providers, public health, and all of us working together?
In regards to my experience with the pop-up clinic itself, while I was so very pleased to be able to host and to partner with the health department, it was one of the questions that I did have, and this was in no ways being less than grateful and appreciative for the individuals who were there, was the lack of diversity among the staff and the volunteers. To come into a predominantly Black congregation, African-American community, it's still, I think just the optics of that is something that I don't think by the time people came there, it wasn't necessarily a concern, because they were coming to get the vaccine. But just even in the ways in which we provide service to the community, which also speaks to other systemic issues, other institutional issues. Well, how many vaccinators of color do we have in the county? How many healthcare professionals of color do we have in the county? But I think that is secondary to the fact that the county and the health systems have done a tremendous job. So to answer your question, what else could be done to keep, working with the partnerships and understanding the larger challenges when it comes to inequities in the healthcare system, for this not to be a one-off, so that the partnerships continue, the conversations continue, that individuals feel connected, that individuals feel heard and valued, so that this time next year, or if there is another pandemic of some type, that the relationship and the foundation has already been there. So we sort of build from here. So to answer your question, I would say sustainability, to make sure, we are able to work with, collaborate, the term that you used, not just for this crisis and this emergency, but moving forward, how do we build to help dismantle some of the systemic issues that we have in our healthcare systems?
Well, thank you so much. And we will continue this collaboration. And I just like to say, as an educator, because I am an adjunct clinical professor at the University of Michigan College of Pharmacy, and I work very tirelessly with our diversity directors and trying to increase people of color at our universities and at Washtenaw Community College. And we will continue to do that work also. So thank you so much for joining us. And I know that you have another commitment to get to. And so we will look forward to working with you in the future.
Thank you. And I do have some time. I was able to move some things in my schedule during the resurrection weekend. So I do have more time if there were other questions. So I'm glad to be a part.
Well, excellent. Just stay right on the line and we may have more questions for you. So next, we are going to have our panelists come in, and I know that they have some slides that they're going to share some information. And so first up we have is Alfreda. Welcome.
Welcome. Good afternoon. And thank you again to everyone who is listening and attending this town hall today, our third in our series. I also want to thank Pastor Evans for being with us today and Dr. Samuels for agreeing to moderate today. I think what's really important, one of the things that I was asked to talk about is to talk about our strategies to improve equitable vaccine distribution. And I think that what we need to really look at the fact is that when we first started this project from the very beginning, we recognized that we could do nothing alone as Michigan Medicine, that we indeed needed to have a partnership. And so from my seat at Michigan Medicine as Director of Community Health Services, it was a no-brainer to me to reach out to Elizabeth Vanderpool, who is my counterpart at St. Joe, Ann Arbor. And so in everything that we have done, it has been a partnership, first with the health systems, just beginning to talk about it, and then be both going to the county health department to say, how can we be of support and what is it that we can help do? One of our first activities that we did was to partner on the pilot project that came from the state. The pilot project allowed health departments and others to band together to request an additional 2,500 doses of vaccine to be used in high SBI areas in the county. So Michigan Medicine, St. Joe partnered with Washtenaw County Health Department on the proposal. And when we found out that we were indeed going to be one of the recipients, one of the things that we did was that we'd already been having conversations with the faith community, Coalition of Black Pastors, which is a combination of 3 different faith community factions in Washtenaw County. And we knew that we couldn't do this without having those types of supports. And so we began to look at where we could begin to partner to host these clinics. One of the very first ones was at St. Francis Church in Ypsilanti, which has a high population of their congregation that speaks Spanish. So we were pleased that they were going to be joining us with that. And then we also looked at the different churches where we wanted to be. We knew we wanted to be in Freight 197. And so we looked at Second Baptist Church in Ypsilanti. We also looked at New Covenant Missionary Baptist Church. Now, what's important about that is that it was strategic as far as location in Ypsilanti. New Covenant is in West Willow. Second Baptist is on the south side of Ypsilanti. We also looked at Freight 105, even though it was an area in Ann Arbor, but they still had a high SVI, but also they had high COVID exposure rates too in the county and confirmed cases. And so looking at that, as well as recognizing that there were other folks that we could reach, not outside of those congregations, we're partnering with Packard Health as part of it. This partnership really and truly bore out of, and the strategic planning took many, many voices other than just the health systems and the county health department. So the racial equity office was there, because if you're going to be talking about equitable distribution of vaccine, you need people who are content experts, because you have to be intentional in your desire to make those decisions, those conscious decisions that expand on equity as opposed to living in equality. Equality is making sure that everybody has access, but equity takes intention in that you have to think about where people are. What are the resources they have to access? You have to think about the comorbidities. You have to think about the number of cases that were involved. And so we brought all of these voices to the table, including people who were not necessarily healthcare providers or public health professionals, and or the ministers involved in it. That's where the Washtenaw County's health department's community voices for health equity, who are people who live in the community, who are part of the community, who had the voice of the community as part of it. And so that was very important. One of the other things I have been asked to explain was, how did we come up with the formula for what we were doing? And I can speak from Michigan Medicine's perspective that when we first started this process, we used a process that was purely randomized. And that process was something that allowed us to create equality across access, but not necessarily equity. As I said, you have to be intentional. And so for us, we use the methodology that we chose to use was to look at where in the community were the highest number of cases of COVID. Confirmed cases, probable cases. And that was in the Freight 197, Freight 198 zip codes. And so we prioritized, after our first round, we prioritized our second round to look at that zip code, but also to look at our patient population, because the health systems had all agreed that they would each take care of their patient population, and the county would partner with other places to make sure that folks who did not have an identified primary care practitioner or physician at either St. Joe or Michigan Medicine, that they would work to make sure that those folks were taken care of. And so when we looked at our patient population, we knew that we had to issue invitations for the vaccine in those areas, and which is what we did. And we did begin to see that there was more of an uptick in those populations. So I will stop there to give other folks an opportunity.
All right. Well, thank you for that. And our next presenter will be Elizabeth Vanderpool.
Good afternoon, everybody. So Elfrida gave an overview of our community outreach pilot project that was in collaboration with the health department, Michigan Medicine, St. Joanne Arbor, and our county office of equity. And we just wanted to show everybody, where we were focused on disseminating vaccines. Through that pilot project, we were given 2,500 first doses of vaccine through MDHHS, which is the state. And so we had 2 weeks to turn around the pop-up clinics. And to Elfrida's mention, we really wanted to focus on areas where we knew that there were high case rates. We knew through talking with community members and community partners that there was not equitable distribution of vaccines, and that there were more people who were also struggling to access our traditional channels to get scheduled for vaccinations. Speaking to what Reverend Evans had mentioned when he had spoke earlier about, people might be calling and they'd get directed to a website, but if somebody doesn't have access to broadband, or somebody might be an elderly person who doesn't use the internet regularly, and they might need assistance, but they don't have that available to them. We really wanted to make sure that we were embedding these pop-up clinics in places that were in community, that people built community around, and that people also had support in. And so you'll see this list here of all of our sites and the dates that we stood those up in. And also I wanted to mention that in addition to working in partnership with pastors and other key leaders in these congregations, Michigan Medicine, St. Joe Ann Arbor, and Washtenaw County, both health department and the equity office, we were making outreach phone calls to people in community, whether they be through patient, an electronic medical record list that we had. For us at St. Joe Ann Arbor, we pulled together, who are people that are, we were really focused on, especially 65 plus in age, living in 48198 and 48197 that do not have access to our patient portal, which is our online way for scheduling, making appointments, accessing your medical records. And the reason that we did that was because we felt that if people weren't using the patient portal, they may also be experiencing issues just accessing the internet in general. And so we had a list of patients that we were calling and just saying, hey, have you had your vaccine yet? Can we help you sign up? There are some pop-up clinics. And we also were asking, do you need help with transportation to get there? And connecting them with transportation if they needed that as well. I think that there might be another slide that gives some information about the project. So this is the data. Like I mentioned, we had 2,500 doses that were distributed to us. And while we were heavily focused on the pop-up clinics, as Elfrida mentioned, we did also have a partnership with Packard Health to get vaccines out through their clinic as well. And so you'll see the data breakdown here and the distribution of race, residence through zip code, and ethnicity as well. And so we learned a lot through the pop-up clinics. This was the first time for us standing these up together in partnership, as Elfrida had mentioned. And our hope is to continue setting up these pop-up clinics in partnership where we can, continuing to work with our faith-based ministries, focusing on the areas of our county that have had high rates of COVID. And again, may have people who can't access the traditional channels to get signed up for vaccines.
All right, our next panelist is Ms. Sindra.
Hi, so this is pretty much what we've done for the county from March 2nd to the 30th. This includes all the Washtenaw County doses, including things at Chelsea, EMU, our Nurse on the Run, as well as the pop-up clinics. And you can see we've almost gone up 3% from March 2nd to March 30th. But we don't know who is part of the other or those who've declined to give their ethnicity or race. And it also doesn't include information from when we started. We just celebrated our 50th clinic, at least at EMU this past Friday, or April Fool's Day as it was. So we don't know from when we started doing the clinics in late December through the beginning of March, how many people have come in through whatever they recognize as their own race or ethnicity. So the number could be slightly higher. But I think through those pop-up clinics and concentrated efforts, we saw a greater amount of people coming through that may have been reached that way than possibly the traditional way. I know the county has been, as mentioned before, people not having access either to technology. We have a lot of people don't have cell phones, don't have an email. So we have made an effort to set up phone banks in our office to make sure people can call in. And let's say they get an appointment, wherever that might be, and don't have an email address, we give them a generic email address that comes back to us so we know to call them, let them know around the time of their appointment that their next appointment is coming. We also, I think the next slide. So as you see here, it still is increase in dosages by the data from March 2nd through the 30th. One of the things is we have about 10% of the data we have for whoever receives a dosage are people that live outside the county, but may work inside the county. And then there's also a large number of our residents that go outside the county to Wayne County, sometime Livingston or Oakland. People right now are vaccine shopping. So we're hoping we get greater numbers of people coming in and the different zip codes. So we're just happy that we can provide this service to get the vaccine out to the community. That's what I've been doing emergency preparedness for like the last 15 to 17 years. And this is what makes me happy, just seeing people come through and seeing the need being met by the community, especially those who are most vulnerable. And for every event that happens, it is usually the people of color that have the most vulnerability in any kind of event. And that's, what we should be working on most. I don't know if there's another slide or not. Oh, yes. So as of April 2nd, vaccine is available to anybody 16 plus. So if you go to this link here and sign up, when you get there, it'll talk to you about, if you go and click on the link and sign up, it may show that there are links, our vaccine slots are already full, but we open up more and more slots for vaccinations just because we're never sure how much vaccine we're getting week to week. We keep hoping it's gonna be a lot more so we can do a lot more out there. But it's always kind of a disappointment when you find out, oh, we're only getting so much. So if you just keep checking back, there's always slots open. And we try to do the best we can at getting people in there. If there are people who are homebound, we have Nurse on the Run. So don't let that be a barrier to getting vaccinated. We try to do, if you can't get out of the car, if you need some assistance, we try to assist people as much as possible in any kind of way when they come to get vaccinated. And there are going to be more pop-up clinics. I know they're talking at the office, going to meet, I think, next week to discuss other pop-up clinics we can do across the county, because we know that's a good way to get to a select percentage of the population that makes it easier for them to get what they need.
Thank you. Thank you so much for that information. Can we have the next slide, please? And Trudy, do you have some information for us here?
Yes, so that concludes our presentation from our panelists, our informal formal presentation, but we will be asking questions. So if you have to leave right now, we ask that you click on the link and get this link, and you can share your feedback on how the town hall has been going. But in a few seconds, we're going to start going questions that people have been submitting. So we hope that you can stick around. If you do have additional questions, feel free to put them in the Q&A section of the Zoom, and we will answer them as we can. So I think we're going to start with some of the questions, and Keela's probably going to go through those. Thank you.
All right. And thank you, everyone who was on the panel sharing us the data. So I really appreciate that as a scientist, researcher person, and anybody listen to the news, you hear Dr. Fauci says, we need the data, show us the numbers, right? So we appreciate you showing us the numbers and the data as we move forward in this collaboration. And I will tell you that one of my favorite words is synergy and synergism. So, we could all do our own little thing in our little pockets, but when we get all the hospitals working together and the health department working together, we get synergy, and synergy is a larger sum. Yeah, we could have been doing everything in our own little world, but this is amazing when we can come together and work together in a synergistic way. So many of you, when you registered, gave us several questions that you want us to address. So I'm going to ask these questions, and any of the panelists can jump in at any point to answer. And the first question we have is, so we have in other seminars, we've been addressing and talking about hesitancy, especially in people of color. Now, I ran across that article a couple of days ago, and they said, I think we're done with hesitancy. A lot of us who have decided to get the vaccine, we want them. And now it's all about distribution. But now the hesitancy may be in some of these younger populations as we move forward. I know there has been a couple of my family members in the last week who are younger, who have been diagnosed with COVID-19. So how can we improve hesitancy in some of the younger population? Because their turn is coming up real soon. Elizabeth, maybe do you have any thoughts on that in our younger folks?
Sure. So, I think that an important thing for us to be thinking about are the channels that younger people tend to get their information from, right? I mean, if you think about the data that we typically pull to understand how people access healthcare information, if you look at people who might be 65 plus as an example, a large percentage of those individuals will say that their most trusted person for information on health is their provider, their doctor. And if you think about youth, where are youth getting a lot of their information, right? They're getting a lot of it on social media. They're getting a lot of it through the internet, a lot of it through their peers. And so one of the strategies that we have been thinking about is how can we utilize social influencers? How can we utilize social media platforms? People that youth are typically looking to and are being influenced by, especially through these kind of social media channels, right? To show themselves getting the vaccine, sharing their experience, right? Working with health experts to debunk some of the misinformation that's out there. And so I think that really concentrating on the ways that youth are getting their information is extremely powerful. And as I mentioned, that's something that we've been thinking about. We have applied for some funding to help us with some of those strategies. And so that's something that I hope that we'll be able to deploy. And I think while youth are really important for us to be focusing on, there still are a lot of people who aren't necessarily in that youth category. We talk a lot about, we've been talking a lot about the Ypsilanti area and the need there, which is really important, right? And we've also started to talk about what's happening in our rural communities. There has been data that has come out that has shown that political affiliation is associated with whether or not people are getting vaccinated. And so knowing that some of our community members that are in rural areas that may have a political affiliation, as an example, right, that may create some hesitancy, thinking about different ways to address folks in those areas too. So I think that, there really is, we really need to be thinking about the intentionality of how we're accessing across multiple age groups, because the article you saw about hesitancy is over, right? I kind of chuckled internally of, I don't know that they're getting that information, right? Because we know that there still are a lot of people out there that aren't necessarily convinced that they want to get the vaccine. And so it's our job to make sure that we can create the best vehicles to make people feel the most confident in making decisions for themselves that will benefit not only them, but their families and our community at large.
That, that was a very, very good answer. And I'm telling you, as far as like, where are people getting their information? And I'm trying to remember, I think it came in like on a social media platform that I saw, and that's it. I mean, we're getting information everywhere, right? And it's like, well, who are we going to believe in? That goes right into our second question. What quick resources do you recommend for people to go to dispel the rumors and the myths and the things that are out there? What's your go-to? Elfrida, what's your go-to as far as getting good information, accurate information?
We tend to go to CDC, but we also have experts at Michigan Medicine who we rely on to also make sure that we are presenting the most credible information. We have members of our medical staff who are part of key communities, key committees, excuse me, with the CDC and with the FDA. And so we know what right now, what the most urgent, what the most current information is, and also what's the most accurate information that there is about the vaccine. And we take that information and we use that to put out, or working with our partnership around communications between St. Joe and the county to get information out in different platforms in different ways. We've also been working on a print piece and using some of our community partners to make sure that we have that accurate information. It doesn't make sense if we have the accurate information and it stays with us. It has to be pushed out. And so using different strategies like working in partnership with places that are also still engaging with community to get these print materials out to folks. Now, what we have to always be mindful of, though, is that when we're putting material out, that we have to make sure it's culturally appropriate for our audience, meaning that it is information that is digestible for them, that really speaks to what their concerns and questions are. And so we use some of the feedback that we get from these town halls to really look at what Michigan Medicine wants to disseminate. And then we're able to say, that's too dense, or that's not the key information that people want. And so that we can tailor it to the needs of the community.
Yes, thank you. I know that this pandemic is definitely a movement target. New data comes out, we have to interpret the data and come up with an answer. So a lot of times when the questions come up, me as a pharmacist, I can only say, what was in the studies, and make it, like you said, go into the CDC website and the FDA and reputable places where we can get information that is current and up to date. So our next question that we have here is, how is equity measured? And I do see that someone in our chat that's live wanted a nice definition of equity, and they said, wouldn't equity in this case be matching at least the Black hospitalization and fatality rates, which was 27 or 22% around in there in our county? So the question is, how are we measuring equity?
So I think that's a very good question to point out those rates, but I think it's also important to always recognize where data comes from and to see data in its totality. The hospitalization rates and the mortality rates If you go back to the county website, which is where we drew data from, we're in those 48197, 48198 zip codes, which is why we turned our resources to supporting and making sure that the patients who were being seen by Michigan Medicine in those zip codes were given access to the vaccine, and making sure that they got the invitations to come. Now, we recognize that there were people who wouldn't have access to the portal, who had not signed up a portal. But one of the things that I don't think that anybody really thought about, and for me, I know it came to me a little bit late, was that I know for my mother, I am her portal expert. I do everything in the portal for her. But when we went on lockdown, we had grandparents who did not have access to the people who would normally do their technology for them. And so that was one of the reasons why, when we started thinking about this, because one of the questions, I can remember being in a meeting and they were saying, well, everybody has somebody who's with them, who's older adult, who does their technology with them. We shouldn't have to worry about that. And I said, no, we got to stop and think. Our grandparents, our older aunts and uncles, they're isolated right now. And so they don't have those people. And so that's why we started calling people instead, both Michigan Medicine and St. Joe started calling people to say, yes, you would have received an invitation to your portal, but just in case you didn't see it, or you didn't get the letter that we sent, because our first line of defense was to mail things, and then had to have the reminder that, remember, our mail is very slow. We don't know when that invitation is going to get there. I'm still waiting for a package that was mailed in December. So we have to wait, seriously. So we have to think about and be much more creative. And that's when we started doing phone calls, because a lot of the things that we would normally take for granted are blown out of the water with this pandemic. And so we have to think differently. We have to think more creatively as we're doing that. And there's one other thing, if I can, I know it's going a little bit out of turn, but there was a question around that was sent to me directly about when will Michigan Medicine be doing pop-up clinics. And I think that what's important to think about it are several things. Is that number one, we do things in partnership. And so when you see folks who are vaccinators and different things in community, it's a combination, especially with the pilot program. We started this, and this is what we plan to continue, that it's using Michigan Medicine and St. Joe personnel who are there, who are volunteering and who are there providing the vaccines. We are doing this in this way because we want to make sure that we can leverage resources across the county in the most efficient way. And we also have to think about the fact that since this is going on a year and some month now with the pandemic, our public health colleagues have been on the front lines in a different way than we have been on the front lines in the health system. They're getting tired. They're getting burnt out because they're going constantly. And so the best support that we can provide as the health systems is to shore up their capacity by sending in folks to help them when they're in those clinics in community, so that we're doing this because we recognize that this is a county response. This is not a Michigan Medicine response. It's not a St. Joe response. This is a county, a Washtenaw County response, because we are part of the community. And we need to make sure that we are shoring up our colleagues who need the best help right now. And so that's why you will see we're going to continue to do things in partnership. Other pop-up clinics will be done in partnership using a combination of resources. And so when you see somebody there, it's not it's them or them or them. It's an us mindset that we're coming and approaching this pandemic by, because that's the only way we're going to defeat it. It's got to be a us mentality and not a them. So thank you.
I like that. I like that. Collaboration. That's what we're talking about. That's what this Zoom meeting is talking about. How we are all coming together to get the job done. It's not you and this person and me. It's us together. The first talk that I gave was about that coronavirus, that enemy, that's it, that we have to attack. And we have to do that at all fronts. So I'm just so grateful. And I really do think that we are doing a good job of putting together. Yes, we have more to do, and we We need to get more vaccine into the arms of our residents and in the people of Michigan. And that has happened with the addition of the new vaccine that was approved. So now we have a new vaccine that is the Johnson & Johnson vaccine. It's a 1-dose vaccine that's there. Now, I'm gonna talk about this. I'm gonna ask this next question, but I do want to say with the Moderna and the Pfizer, you know, I had talked about that and how it was messenger RNA vaccine. And now we have the Johnson & Johnson is one and done, and it's a adenovirus vector vaccine. And one of the questions that came up was, well, we're not seeing as effective rates with that as we saw like 95% with the first two and around 70% in the studies of the Johnson & Johnson. But what I want to tell you all that all the vaccines that we have on the market are effective against that enemy, against the coronavirus. And even with the Johnson & Johnson, we're looking at over 85% efficacy rate of keeping people out of the hospitals. That's what we want. We don't want them coming, having severe COVID and being hospitalized. So they are effective. So the next question, going back to our topic for today in equitable distribution, if we have someone who turns down the Johnson & Johnson, will they be allowed to get the Moderna or Pfizer vaccine? So if they come to the clinic and it's not the vaccine they want, how do you handle that?
So each of our clinics, based on whatever vaccine allotment we have, our clinics may have different things. EMU is strictly Pfizer. So, you know, you come get one, you come back 3 weeks later, you get your second dose. Our Chelsea clinic has been sometime Janssen, which is Johnson & Johnson, or Moderna. And we don't offer up, you don't get the opportunity to say, I want X, Y, or Z. This is what we offer here. If you like another vaccine, then you may try to shop around at Rite Aid, Myers, or whatever other entity you can get the vaccine. But we're not allowing, we don't have the space or the vaccine amounts to offer up, you know, your choice of vaccine. So we tell people the same thing. I know some people didn't want the Johnson & Johnson, and then we were offering it up in one of our other clinics. And they're like, oh, you're offering it there? And it's like, yes. And I think part of that was thinking that if we offered it to the pop-up clinics, which were primarily African-American community, that we were offering something less than. And I think that's been a huge problem with the one and done. They think it's less than, and we're offering it to you because you are less than. But we've offered all three in different capacities to all communities of color. So I really do think the best thing to do, like you were saying, is just they're all effective. They all do what they need to do, is keeping people out of the hospital, lessening death. But if you really have a preference of whichever one you want, there are other markets that you can get it from other than the health department. It could be what Michigan Medicine offering at their clinics, or what St. Joe's or IHA are doing, or any of the pharmaceuticals, but they're all very good vaccines. We don't, as a public health department, try to just figure out who can get what's better into which population, be it race, sex, class, whatever. All we're trying to do is eradicate what you call the enemy.
Yes. Well, I know I'm telling my patients, and I've been on several Zooms and conversations about the vaccine, get on everybody's list. We want to get this done. We want to reach herd immunity, right? Where we can kind of figure out what our new normal is going to be. I want to know what a post-pandemic world is going to look like. So to get there, get on everybody's list and let's get it done. So our next question is, again, talking about distribution, how are we going to ensure that underserved clinics like our Hope Clinic, our wonderful Hope Clinic that we have in Ypsilanti, have a sufficient amount of vaccine for their patients?
Hi, I'll speak to that. So our physician network, IHA, has been working with Hope Clinic to train their staff on being able to vaccinate. I believe that they started with the Johnson & Johnson vaccine, and are exploring, if we're able to, given supply, also provide Moderna and Pfizer, and Hope has the capacity to be able to set up those, multiple times for people to come and get their vaccines. We'll be working to train folks up on that as well. And, I think it's important for us to recognize that while we, as the, some of the main vaccine providers in the community, are working together, there are a lot of grassroots efforts happening that maybe we're not totally tapped into. And so I think one thing that we've talked about recently is, how can we make sure that we are reaching out to our networks and our connections and community as much as possible to say, hey, if you have some volunteer efforts going on in your community, right, to help people figure out where they need to get vaccinated, or maybe folks are, getting information from the CDC and getting it to their neighbors, right, through neighborhood association or whatever that might be. Really trying to make sure that the connections between the grassroots efforts are happening with the vaccine efforts and education outreach efforts that we have going on, so that if by chance one of those grassroots efforts happens to influence somebody to say, oh, I didn't really know before, but now I feel like I really do want to get the vaccine, they have an understanding of, great, I have the information about the vaccine itself, but I also have the information about where I can get it. So there's that connection between those two components that I think is really important. And Hope Clinic is a great example of an embedded community entity that we can continue to build relationships with, to say, hey, now that we've trained up the staff, you have vaccines coming in, what are you continuing to hear from community? Are you really still getting people that are hesitant? What can we do to provide some support through information and education? Or if they're seeing more people at Hope Clinic than they can handle from wanting a vaccine, right? Maybe there's something we can do to partner with them to increase their capacity through a pop-up clinic or something of that nature. So I think those interconnections and partnerships, as Alfreda was mentioning earlier, are just really valuable in making sure that we can create a deeper impact than we might be able to do alone.
And if I could just add to what Elizabeth said, Michigan Medicine is also supporting Hope Clinic with vaccine. So we're, when I keep saying it, I can't stress this enough, this is not a you versus somebody else, this is us doing this. And so we are all partnering together to make sure that every aspect of the community who has a need it's being met. But if I could also just bring up one more point about Johnson & Johnson vaccine, in that Johnson & Johnson is really good for those transient population and for our homebound folks, those folks who it may be very difficult for them to be able to get to an outside clinic to be able to go, or you have to get them while they're in front of you because you don't know when you're going to see them again, if they're going to make it back around to you for that 3-week or 4-week second dose. But it's also that when we think about our homebound folks, it's really great because how it can be carried. It doesn't have the same kind of handling as you need to do for Moderna or Pfizer. And so it makes logical sense. And especially if it does what it's supposed to do, which is prevent serious illness or prevent death from COVID, then it is of equal value as every other vaccine that we have. Does not, just because you may have to do more for something doesn't mean it's less. It means that it's equal in value and impact of preventing serious illness and preventing death.
Absolutely. And as a clinician, I definitely agree with that comment. So getting it done. So the next question is kind of interesting. Using age criteria inherently discriminates against populations with lower life expectancy. How can we remedy that? So we're talking about people that, you know, our older population or lower, or maybe because of illness, lower life expectancy. Um, any thoughts on that question?
Keela, I wonder if you can say a little bit more
Yeah,
about what the person is looking for.
um, I'm not really sure. I read the question as, you know, sometimes with older people that have shorter life expectancies, and or if someone is going to die, are there going to be any age discrimination, you know, against people like that? That's how I'm reading that question.
No,
And I'm seeing no, no, no. You come and get your appointment. We're gonna
well,
give you that vaccine.
I think that's been one of the hardest things when we started getting vaccine. We concentrate, the state said, or the CDC said we should start doing 65 plus. Washtenaw County started doing, we're doing 75 plus because we know that age group is hit the hardest by a lot of things. And then we started just going back up to 65 plus, but we were looking for, I mean, we have people come through every day who have cancer or other extreme health issues. And we're not saying, oh, you have, you know, you're going to die in 30 days. I'm sorry, we're going to keep this vaccine dosage for somebody else. We want everybody to be protected as soon as possible, as much as possible. So we've been totally just looking at and focusing on seniors first. And now we're glad we can open it up some, but even saying that we still want the seniors to get the most bang of the buck first before we can go further.
Hi, this is Trudy. I'm going to jump in here because I think one of the questions that came up is for folks who are interested, who want to understand. We already know that Black and Brown populations have a lower life expectancy. So why aren't they prioritized first? Because you know, the Caucasian population is 75, 80. For Black populations or Black males, it might be 50. So why weren't they prioritized first?
Okay, I guess I'll dip my toe in first, and we'll see if my other panelists can come and help me. I think that if you remember earlier, I said that one of the things that we recognized was that the process that we had looked at was randomized. So at Michigan Medicine, our patient population, because remember, each health system was charged with taking care of their patients. Our patient population is 82% white, 9% African American Black, 5% of Asian descent, and then the rest of the percentage is a combination of Asian Pacific Islander and Native American. When we went back and realized that the process that we were using was a randomized equal process, we really needed to change our focus and be intentional. And so that is when we did go back and issue invitations that were based on many things in addition to race, ethnicity, but also chronic disease state, what people had, were they high risk or not. And I think that as we are thinking about this, we were intentional, we oversampled in those populations that were at highest risk, those Black and Brown populations. But when you're talking about equity, equity kind of flows both ways, in that you're looking at equity for everyone who may be at high risk, but we are also focusing on those people who have more risk. And so it wasn't that we would just automatically start out and we would just go straight into Black and Brown communities, because there were still people in other communities who were impacted as well. And so when you're looking at that, we have to be very mindful that we are not discriminating or causing harm to another group when we prioritize a particular group. And so equity is making sure that everyone who, even like I said, we're building on those folks who have higher risk, were impacted greater. Those are the criteria that you use, but it doesn't mean that you don't do anybody else in that process. It means that you intentionally create more opportunities for those folks. I think the other piece that we have to also remember is that at the beginning of this, that was to me when there was some hesitancy. And so we knew that was going to happen. And so these town halls that we have been having, we started having conversations in October when we knew that there was going to be a vaccine, to say, we've got to do two things. We got to provide education, we got to provide access. And so this is the other education piece to build up the momentum for those folks, because the first time around when Michigan Medicine issued invitations and they focused it on the area in Washtenaw County that was hit the most, we sent out, I think it was like 1,800 invitations, and only about 600 people, 720 people actually took us up on that and came in and got vaccinated. And so it's not just, why didn't you start there? It's starting there, but being culturally appropriate in how you reach out, how you create that equity, and how you make sure that people have information for informed decisions. And that you're not, again, creating more disparity.
Yeah, I think too, to Elfrida's point, we went through a very similar process through St. Joe's and through our physician network, where we started with these randomized processes, and then we kind of had to take a step back and say, well, that may be equal, but it might not necessarily be equitable, especially given that our patient population demographic is very similar to what Elfrida had mentioned at Michigan Medicine, right? We have a lot more white patients than we do minority group patients. And so I think that was another piece for us to step back and say, okay, we also need to be doing, as Elfrida mentioned, with the outreach and the education piece, and what are these other things that we can continue to bolster in the community? How can we be more intentional about partnerships that we have, right? Which from that came the relationships with the Ministerial Alliance and doing these pop-up clinics, working with our food pantries and other nonprofits and community, where people that we know, that are coming that already may not have access to those traditional channels, may not be a patient of one of ours through our physician networks. So we wanted to make sure that we were taking as many channels as possible once we recognized, okay, this randomized process really is not going to get to everybody that it needs to get to. And what more do we need to be doing to be equitable and not just get equal in the processes that we're rolling out?
And if I could, Keela, there was another question that came to me about when will Michigan Medicine report demographic data for their vaccine intake, is much the same way the county does. And we have been thinking about and talking about how we can do that, because not everyone, as the county has found out, and that data gives race and ethnicity data. And so we're thinking about what is the best way to go about doing that so that we will be able to present accurate information. You're muted, Keela.
Keela, you're muted.
Just got a few more questions here. And I think it was you, Elfrida, that was talking about SBI. One of our attendings wanted to know, what is that and why is it being used, and whether the state mandates its use in distribution. Maybe it was Elizabeth. One of you said that, SBI.
I can take it, Elfrida. So SBI, it stands for the Social Vulnerability Index. And this is actually something that when vaccine distribution rollout began, the Center for Disease Control, the CDC, had suggested that this be a lens through which state and local municipalities looked at how they were distributing vaccines. So the social vulnerability index is basically taking into account factors that contribute to someone's socioeconomic status. So do people have ready access to transportation? Do people have ready access to employment? Do people have ready access to food, right? And so there are all of these components that contribute to a county's and then a state's social vulnerability index. So yes, the state has used this social vulnerability index in distributing their vaccines. You may have seen through some, news media outlets that Wayne County in the city of Detroit, when the state really started to use the SVI index much more heavily, when vaccines increased a little bit more in supply, they were sending a lot more to that area, and there was kind of a lot of media out there around that. That was because if you were looking at the social vulnerability index map of the state of Michigan, there are they do it in shades of blue. And the darkest blue is an area with the highest SVI. And, Wayne County and Detroit were one of those areas. And so for us locally, and I know that the health department is using this heavily in their decision making as well, we were saying, well, the state is using this, but we also need to be using this locally to be thinking about what are the social vulnerability index indicators of our community. And then we also layer that on with other data as well. So what we've talked about throughout our presentation today, thinking about case rates, that's another really big component of our decision-making process. So there are a bunch of different lenses that we use, but the social vulnerability index is one that is used both or from the national, state, and local levels, and is a consistent strategy that a lot of distributors are employing.
And if I could piggyback on that, I feel like I have been talking too much already. I want to give somebody else another opportunity. Is that what we also recognize? I was on a call with some of the ministers, and one of the ministers posed a question about if you're using SVI, but SVI does not talk about those small pockets that may be in a zip code that does not have a high SVI, but a very low SVI. So what do you do about that? And the example that they gave is 48103. That zip code is not have a high SVI, but there are pockets in that zip code where there are people who do live in poverty, have poor access to food, have poor access to transportation, are not employed. And so it is a strategy, but I think that with everything, we also have to look at what are those other outliers or those other factors to make sure that we are reaching those pockets of population that don't fit into that larger high SVI model that we're currently using. And so that's why it's very important that we be creative and that we bring in other variables, which is what and that's a collaborative we try to do to make sure that we're reaching everyone who needs to have a vaccine in the county.
Well, great. Thank you for that explanation. So I have a question now that we got our appointment, we're getting our vaccine. What type of support is going on at the site when someone has some type of reaction, or the possibility if they were going to have an anaphylactic reaction? What's there to help them?
So at any of the health department sites, and I believe some of the pop-up sites as well, we have HVA there, or our local EMS agency. And we want them there because that takes some of the stressors off of our nursing staff and clinical staff. So if something does happen, they're right there on the spot to assist. So far, we have not seen any major reaction to the vaccine, but what we have seen are the anxiousness of people coming in and just kind of, they've been reluctant to get the vaccine. They finally at that edge, they want to get it, and then they're just kind of really nervous. Or we've had people just, I guess they just start getting a rash just because they are so anxious. So we haven't really seen anybody have an actual anaphylactic reaction, but we have HVA there just in case, and that makes a world of difference. And I think it makes the people in the community when they're there feel a little bit better.
The supportive systems that undergird, well, I can say at Bethel AME Church, were excellent. I mean, just the conversation, the things to look out for as far as side effects, not side effects, but rather just your reaction, your body's natural reaction to the vaccination. As far as flyers, written information, it was a very kind of wraparound process so that those who were vaccinated felt supported.
That's awesome, and that's very good to know. I know that another question that came up about allergies, and hopefully we will continue this conversation and talk more about this later. There was something we were talking about getting reputable information, and where are we getting like our news. So there was a question about people that had fish allergies. So right now there has been nothing in our data that is linking any food allergy with the vaccines that are out there. So just wanted to give you that information. Well, we are kind of winding down. I think we have about 4 minutes left to our session today. I think I want to just take this last 4 minutes and kind of just have a little round table from our panelists as to giving some last minute nuggets, thoughts on the work that you're doing, distribution, just some take home messages for our audience for today. So let's start with you, Cinda, a take home message for our audience today.
Well, one thing is I would love if people wanted to volunteer. We're always looking for volunteers at our clinics. It was talked about earlier, representation, and I think that's important to see yourself when you go somewhere. So if more people, Black people, people of color would volunteer, that would be great. And you can either volunteer through our local Medical Reserve Corps, which you can find on our website, or the state's volunteer registry, and you get to say which county or which area you want to volunteer in. And also, I don't want transportation to be a burden for people to get to our clinic in Ypsilanti, EMU. So ADA has they have a flex ride stop there, and there's multiple stops at the Ypsilanti parts of Ann Arbor. So if people do need a ride, it's no charge to the client. It's being funded by COVID dollars. So we want people to come out and not have any excuse if they really want the vaccine and can get there. We don't want barriers. We want to make it barrier free for people to get there. And we promised it's a very happy group there. Sometimes they do the YMCA dance in the atrium while people are waiting there 15 minutes. So it's always a fun time there.
Thank you. Elfrida.
Thank you. I think there are several things I'd like for people to take away. Number one is that we have entered into this as a partnership. You've heard me say that, but I don't think I can stress it enough that St. Joe, Michigan Medicine, and the county through several departments are working together collaboratively to make sure that people have access to vaccine. Number two, I think it's also important that whatever information you hear today that helps you make an informed decision, that you share it with someone else. I know that in my family, I am normally that person that my mother will call to get information, and she'll start it off by saying, well, Miss Carmelita had a question. And so once I give her that answer, I know that she's going to give it to like 3, 4 more people. And then they too are going to spread that message, because we have that tradition of having those trusted folks who we can speak to and we can call on our family to verify information. And so it's important that each one of us take the opportunity to make sure that we're reaching someone. And then thirdly, I think it's important that throughout all of this, that there are guidelines and parameters and things that we have to work within, and that we are doing, we're doing the work and using the best resources that we have to make sure that we are reaching and connecting with people. But I also think it's important that you recognize that folks out there recognize that I hear what you're saying. And I take what you say to me back to the powers that be at Michigan Medicine to say, this is what we need to do better, and this is what we need to do differently. So if there are questions that did not get answered today that were specific for Michigan Medicine because of time, please know that I will be taking those back and we will get that information out. If you want a direct answer, if you would include your email address, we're happy to give you a direct answer. But I thank you for your time today, and I thank you for listening to, and I hope that we have answered the questions that you had. Thank you.
Thank you. Elizabeth.
I just want to thank everybody for participating and for asking questions and asking some of the hard questions for us, right? I think one of the things that, we had talked about earlier was, we rolled out some processes and there was a lot of community feedback, and that really paused us, as partners in community to take a step back and say, wait a second, maybe we need to be doing things differently, right? The community is telling us that we're not going about this in the best way and that people are being missed. And so I think that community partnership and community feedback and, coming to us with questions and hard questions or easy questions, to Elfrida's point, with us being in community, hearing these things, we take them back and we say, we keep hearing this from our community, and it's telling us we need to be doing more and we need to be doing different. So what can we be doing to make sure that we're meeting the needs of the community? Because at the end of the day, Frida kept saying it's an us, right? It's not this hospital and the health department, while if you look at hospitals and clinical competition and trying to get patients for here, XY procedure, whatever, right? This is not that. This is something that we feel is extremely important to work together on, because we know we are greater together than we are apart, in affecting our community. And as separate institutions and together, we feel that social responsibility is a core value that we want to uphold. And we want to show that through the partnerships that we are making in community and through the impact that we hope that we're having, by listening to what people have to say and adapting our processes to be more equitable for our community members.
Thank you. And Reverend Evans, thank you so much for sticking with us through the end. So drop some wisdom and knowledge on us.
I don't know about that, but I certainly am grateful for this opportunity. And just the takeaway points within the Christian faith, this is the weekend we celebrate Resurrection Easter. Within the Jewish faith, this is the culmination of Passover, both of which speak to opportunities for new life in the face of chaos, confusion. And I think we've had some confusion over the last 12 months, but working through that to see these opportunities through collaboration and partnership, it's exciting. There's a lot of work that needs to be done. But I think as we move into a new normal, that these partnerships, these collaborations, the synergy will breathe life into our communities.
Absolutely. Well, again, thank you all for joining us this afternoon. You definitely have enlightened me on some new subjects, and I hopefully and hope that all of our participants were blessed and got some new information. So, Trudy, you want to end us out?
Yes, thank you all for attending today, and thank you so much for your questions. Up on the slide now is just something that we got last week that we wanted to share. Ypsilanti Township is partnering with Rite Aid to have several pop-up clinics over the next couple of months. So just wanted to share that, but we also know that there will be more pop-up clinics coming out next week as well as the eligibility opens up. If you have not had a chance, we would greatly appreciate you giving some feedback on our town hall today. And there is a link in the chat. And also I will be sending that out by email. And I think that is all. So I'll let Frida give closing remarks, and thank you all.
So again, thank you everyone who participated today. And thank you to our partners who helped make this event possible. But thank you to the folks who came. We know this is a busy weekend. Some folks are out of town. And so we appreciate you taking time out of your day to be here with us. As always, if there are questions that we have not gotten to, we will get those out as a frequently asked question. This recording will also be available on the Program for Multicultural Health website. And so if you have any other questions, please feel free to reach out. But other than that, we ask that you, even if you're vaccinated fully, first and second dose, please continue to wear your mask. Please continue to wash your hands. Please be mindful because we're still in the thick of this. And so I thank you so very much for your time today.